Hi, my name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm the director of the Cardiothoracic and Stereotactic Body Radiation Therapy Services and director of clinical trials. Some of the very same factors that predispose a patient to developing lung cancer are also the ones that make it so challenging to treat. For example, as a patient gets older, that increases the risk of them developing lung cancer, particularly as it relates to the extent of their smoking history. Also, many patients have poor performance status due to their underlying cardiopulmonary comorbidities, often again associated with smoking, such as COPD or other cardiovascular problems. So these very same things that predispose the patient to being at higher risk of lung cancer are also what make it challenging to treat. Now, first, it is important to separate elderly from poor performance status. These often get lumped together in these discussions, but they are separate problems. There are plenty of elderly people who have high performance status and are very functional. Increasingly, I see many people in my clinic who are older, but certainly look younger than their stated age and are highly functional. In comparison, poor performance status can also occur in patients who are younger. There are patients who have had considerable medical comorbidities even in their young life, and by the time they're in their early 50s or 60s, have you accumulated many of these such that they have a very poor performance status and are not very functional at all. So that is important because just like we saw with some of the early chemotherapy trials, and we're also seeing with definitive chemoradiotherapy trials, age alone should not exclude you from receiving aggressive definitive intent chemoradiotherapy. I've treated many patients in their 80s or above who do just quite well with it. However, I think between those two, poor performance status is a much more significant problem to deal with. These patients often struggle with receiving a full course of definitive chemoradiotherapy, oftentimes something like weekly carbotaxol with 6 weeks of radiation, or cisplatin etoposide, or any other regimen that's been approved. All of these can be challenging to deliver when you try and give the chemotherapy with the radiation in these patients. And the primary reason is somewhat obvious, but certainly worth stating. When you add chemotherapy to radiation, the side effects are not 1 + 1 = 2, it's 1 + 1 = 5. There is a much more increased risk of adverse events such as esophagitis and fatigue and anemia or leukopenia when you combine these treatments together. The other thing is that ultimately many of these patients may struggle to even get back and forth to the clinic every day. So because of the challenges for the patients with poor performance status or difficulty getting back and forth to the clinic or an inability to tolerate the systemic therapy, there has been increasing interest in using radiation alone. However, we also know from historic data that radiation alone is going to have a low chance of curing that cancer without the chemotherapy. To try and improve our chances, we try to increase the dose per day, also called hypofractionated radiation therapy. Now, this is something which has been practiced actually in head and neck cancer for quite some time. In patients who have head and neck cancer, there have been trials that have shown in patients who don't get chemotherapy that mild hypofractionation significantly can improve the chances of cure compared to standard dose and fractionation radiation. What do I mean by mild hypofractionation? If a standard radiation treatment was given at 1.8 gray to 2 gray per day, a hypofractionated treatment might be in the order of 2.5 to 3 or sometimes 4 gray per day. When you start to get to doses closer to 5 or 6 or 7, that tends to fall more into the stereotactic radiation treatment dosing. So a typical course of hypofractionated radiation alone for a patient with poor performance status might be something like 45 to 60 gray delivered over 15 radiation treatments. Now, this has some significant benefits. The dose per day increases the rate of sterilization of the cancer compared to standard dose radiation. Collapsing the treatment course down to 3 weeks makes it a lot easier for the patient to get through that treatment. And in fact, right when most patients would be starting to get their worst side effects, which is typically around week 3 for most chemoradiation courses, they're done with treatment. There have been multiple early phase clinical trials out of several academic centers that have been published over the last few years looking at this specific patient population and the ability to deliver this treatment, and they universally show the same thing. Patients are able to get this treatment. The risk of acute adverse events are low. However, there is still the potential for late adverse events in these patients if they live long enough. As you increase the dose of fractionation per day, you are also increasing that exposure to the esophagus and blood vessels and other things. And then therefore the risks are to those organs that may happen maybe 1.5 to 3 years later, such as stricture or fistula, which can be sometimes fatal. So that's ultimately why you need to be careful about the patients you select, both in terms of their performance status and their potential longevity. The other thing that matters is the extent of disease. Something that's more discrete and more constrained to the chest and a low lymph node burden is going to be a better candidate for hypofractionated radiation than something which is more extensive, where you're exposing more of those tissues to radiation. In patients who present with much more extensive disease, where hypofractionated radiation is a suboptimal approach, separating out the chemotherapy and radiation may be an alternative approach, where you can give the chemotherapy first and then follow that with radiation, kind of working backwards in time from where we were before, where that was actually the case initially, where we gave serial chemotherapy and then radiation. And many patients who might not get through concurrent may be able to get through a sequential treatment. So overall, it's important in this patient population to really tailor the treatment to the patient. Again, remembering to separate elderly from performance status because they are not the same. And then looking at the extent of disease to determine their ability to tolerate concurrent chemoradiotherapy, sequential chemoradiotherapy, or perhaps hypofractionated radiation alone.